the introduction slide?
Um,
You want to keep?
I think we should keep
on the slide here.
I think we should keep John's slide.
Okay.
Yes, although these systems and programs like Zoom are wonderful, they do instill some nervousness when you are actually using them.
I'm still nervous every time I join the meeting.
Because if you're present in a lecture room and the technology fails, then you can always get out a whiteboard and a pen and just write things on it.
Yes.
Okay, I think we've got 1 minute to go.
Okay, it's 1 p.m. so we should start the session in this afternoon. So good afternoon, Chairman Ajahn Savitri Asanangkornchai and Ajahn Pichai Sangchanchai and Professor John Saunders and everyone. My name is Pat Ying Rasamon Kalayasiri from the Center for Addiction Studies, Department of Psychiatry, Faculty of Medicine, Chulalongkorn University. And I would like to welcome everyone to today's special event. This event is organized by the Center for Alcohol Studies, or SOWS, or ศูนย์วิจัยปัญหาสุรา together with the Thai Society for Addiction Psychiatry, or TSAP, and the Center for Addiction Studies, or SOSOG. And we organize this special event to emphasize the importance of the diagnosis for substance use and substance dependence. And next year in 2022, I think the ICD-11, which was developed by the WHO, World Health Organization, will be effective in use. So today we are honored to have Professor John Saunders, who is the lead expert and have worked a lot on the ICD-11, and that will be used next year. And he will give us the overview of the diagnosis, the details, and at the end, Ajahn Thirayut Rungirandon will show us case for the diagnosis that related to substance use. And Ajahn Pongkwan Kimsat will be our moderator as usual. So Ajahn Pongkwan, please.
Okay, so our schedule for today will be start with the opening remarks from Dr. Savitri and Dr. Pichai, and then Professor John will give us a talk about ICD-11, and he will present two case discussions followed by the Q&A session, and then we will have another case presentation from Dr. Thirayut, and finally we will closing and wrap up by Dr. Rasamon. So first of all, I would like to invite Dr. Savitri, Director of Center of Alcohol Study, to give a welcome and opening remarks.
Thank you, Pongkwan. Professor Saunders, friends and colleagues, I'm very pleased to see you all in this seminar. As Rasamon said, this is a joint meeting between the Center for Alcohol Studies, Center for Addiction Studies, and TSAP. So as the director of our Center for Alcohol Studies, let me briefly introduce the center. The CAS is an academic organization mandating to produce and disseminating knowledge related to prevention, control of alcohol-related problems, to support capacity building of network partners, advocate for policies, and mobilize the society. So we work both as a research producing agency and a research funding agency. So any of you who are interested in doing research related to our goals can apply for research grants from us. One of our main missions is capacity building of academics and stakeholders. So today meeting serves this objective. Today, I'm particularly happy and honored to have Professor John Saunders with us. John was my PhD supervisor when I was doing a PhD in Sydney University, Australia, about 20 years ago, more than 20 years ago. Yeah, I think John's the best supervisor anyone could have and has become my lifelong mentor since then. After my PhD, he has still guided and supported me in some international work until present. We both were members of the WHO work group for the development of ICD-11, substance and behavior addiction. So before going to the meetings of this task in Geneva, I would write to him and ask for his advices on how to prepare myself for the meeting, and got very useful advices every time. I consider myself as a lucky person for this and was very happy every time I met him in any WHO or other international meetings. I think most of you here are familiar with the audit alcohol screening tool of the WHO, which we have it translated into Thai and used a lot in both research and clinical practice here. Do you know that Professor John Saunders was the key person in the development of this tool? John is also the lead author of the book on the lead editor of the book on addiction medicine, of which I'm very lucky to be involved as an author for some sections in the first and second editions, and also an editorial team for this third edition, which is being prepared now. Well, before I speak too long about Professor Saunders, I want to say that I'm very grateful that you accept my invitation to speak in this seminar today. And I'm sure that we will learn a lot from the real expert in this field. And I would like to give the task of formal introduction to General Pichai Sangchanchai, the president of TSAP. Please.
Good afternoon to Professor John Saunders and everybody. First of all, I would like to introduce our special lecturer today. Professor John B. Saunders is a consultant physician in internal medicine and addiction medicine at the University of Queensland and Sydney and the St. John of God and Wesley private hospital groups in Australia. He graduated medicine from the University of Cambridge and specialized medical training in internal medicine, gastroenterology, and liver disease and addiction medicine. His career as a clinician, service director, researcher, and academic in the alcohol and drug field over 40 years. He has screening and early diagnosis, brief intervention, assessment instruments, susceptibility to alcohol and drug related disorder, treatment of alcohol, opioids, and psychostimulant disorders, and medical education in addiction study. Professor Saunders has worked with the World Health Organization for many years and was responsible for developing the audit questionnaire. He is the member of the WHO Expert Advisory Panel on Substance Abuse and the ICD-11 Substance-Related and Addictive Disorders Work Group, and was previously co-chair of the DSM-5 Substance Use Disorder Work Group in the year 2003 to 2007. He is founding and emeritus editor-in-chief of the Drug and Alcohol Review. section editor for addictive disorder for Current Opinion in Psychiatry, and member of the editorial board of Journal of Studies on Alcohol and Drugs. He has been a member of many state and federal Australian government committees, including the Australian National Council on Drugs in the year 2001 to 2007. Professor Saunders has published 6 books, including Addiction Medicine, published by Oxford University Press, Young People and Alcohol, and over 360 scientific papers, reviews, and book chapters. He is an ISI highly cited scientist with accumulated citation exceeding 33,000. Now, we really appreciate to have Professor John Saunders to give us noteworthy lecture in the topic ICD-11 disorders due to substance use and addictive behaviors, how to make diagnosis and classifications. Please, Professor John B. Saunders.
Thank you very much, Major General Pichai and Professor Sawitri and Associate Professor Razmon for your very generous introductions. I appreciate that. It is clearly an important topic that we address in the seminar today. The disorders due to substance use and addictive behaviors as they feature in ICD-11. And let me just indicate the importance of ICD-11 in that this is a photograph of the WHO headquarters building in Geneva with the WHO flag flying, and you will see that the World Health Organization is responsible for the development and review and update of international classifications of diseases for the world. And member states of the United Nations and WHO agreed to use ICD as the standard for collecting and reporting of health information and to guide their provision of health services for their people. I should declare some interests. I have worked in WHO or for WHO in some capacity since 1981. I have also worked in the development of DSM-4 and DSM-5. I've not received any remuneration in relation to this presentation. I have no conflicts of interest to declare. Now, let me just give you an overview of the ICD-11. It includes a new grouping of conditions, which is called disorders due to substance use and addictive behaviors. The diagnoses in ICD reflect and emphasize the public health approach to substance use and addictive disorders in support of the WHO's overall strategic objective in minimizing harm from substance use. This is a very important conceptual diagram. I call it the pyramid, and it emphasizes that in society as a whole, there is a range or spectrum of substance use and disorder due to substances. It ranges for a particular substance in a particular country from 0, and that would be represented by the people at the bottom of that pyramid, through to low risk use, through to hazardous or risky substance use, various forms of harmful use, And at the top of the pyramid, there is in the ICD system a disorder called substance dependence, which is the addiction to a substance. Now, looking at the ICD-11 diagnoses, and so if you look just to the right of that pyramid, you will find substance dependence, harmful substance use, episode of harmful use, and hazardous substance use. And these four diagnoses represent the primary substance use diagnoses in the ICD system. They are mutually exclusive, which means that for a particular substance, you only diagnose one of those, the one which is the most important, i.e. the most severe, providing the patient fulfills those criteria. Now, there is a conceptual difference between the ICD understanding of substance use disorders and that of the DSM system, especially DSM-5. ICD emphasizes the range of use and of disorder. DSM, by contrast, has a single diagnosis of substance use disorder, which is a combination of the previous disorders of substance dependence in DSM-4 and substance abuse in DSM-4. But it does not seek to diagnose hazardous or risky substance use, and it does not encapsulate this spectrum of use. So in DSM-5, for example, you either have DSM-5 substance use disorder, or you don't. If you do have DSM-5 substance use disorder, you can further specify it into mild, moderate, and severe, but you do not encompass the total range of substance use which you see in society. Now, in every patient who has any substance-related diagnosis, there is a requirement to state which one of these four primary diagnoses apply. The primary diagnosis for a particular substance informs the clinician's response in terms of devising the form of treatment or response which is most appropriate. It also influences the public health approach, because primary prevention is oriented to the whole of the community, including people with zero use and low risk use. And primary prevention aims to prevent the uptake or escalation of use, particularly in vulnerable groups such as children, young people, and pregnant women. Secondary intervention, often called brief or early intervention, seeks to identify those with hazardous or risky use or some form of harmful use, with the aim of helping them reduce their substance use to low risk or zero levels. Treatment and rehabilitation are, of course, particularly oriented to those who have substance dependence. And we should also mention the broad harm reduction approaches, which apply to those who have hazardous, harmful, and dependent substance use, and who choose not to modify their pattern or their level of substance use. So the WHO concept of this spectrum of substance use and disorder informs the international and national responses to the prevention of substance use and substance-related harm, early intervention for people who are at risky or early harmful use, and also the range of treatment services for those with established disorders such as substance dependence. Now, what is different in ICD-11 compared with ICD-10? Well, first of all, there is an expanded range of substances which are covered. Indeed, 14 substance groups are covered in ICD-11 compared with 9 in ICD-10. I shall describe the substance groups in my next slide. In addition, there is provision for the diagnosis of disorders due to other substances which are not covered in those 14 groups. And also, it includes diagnoses of disorders which are due to non-psychoactive substances, such as laxatives, where the laxative use has caused harm. So, for clinical and public health reasons, clinicians and everybody involved in diagnosis are expected in the ICD-11 to identify, first of all, the substance or substance group that applies, and then the appropriate clinical syndrome. So this table shows the specified substance groups in ICD-11, and as you can see on the left, you see a number of central nervous system depressants. In the middle column, you will see substances which are central nervous system stimulants. And in the right-hand column, you will see substances which have mixed effects or are hallucinogenic or dissociative. So there are 14 in all. I mentioned that there are 4 primary diagnoses in ICD-11, and I shall spend some time in covering these. As I said, these 4 diagnoses one of them should be diagnosed in every patient who has some form of substance disorder. There are diagnostic guidelines which apply to each of these 4 conditions, and I will go through them. They are hierarchical and mutually exclusive. So what that means is that for a given substance, such as alcohol, for example, you have to choose which one of those 4 diagnoses to make. You can't make all of them. You can't make 2 of them. You can only make 1 of them. So if you have a patient who fulfills the guidelines for the diagnosis of alcohol dependence, that's the diagnosis. You don't also diagnose hazardous alcohol use, even though you think that the patient fulfills the diagnostic requirements. So you choose the most severe disorder. You can, though, diagnose a different disorder in another substance. So, for example, you might have somebody who is a heavy cigarette smoker and you diagnose nicotine dependence. That person might also smoke cannabis, but has never experienced any harm as a result of their cannabis smoking. And so you might in that person also diagnose hazardous cannabis use. So you can have different diagnoses for different substances. There are also additional diagnoses available for particular clinical syndromes. So there are diagnoses, diagnostic guidelines for substance intoxication, substance withdrawal, and various substance-induced mental disorders and substance-induced physical or medical disorders. And these diagnoses can be made additionally to one of the 4 primary diagnoses. Let me now go to the disorder at the top of the spectrum, or the top of the pyramid. That is substance dependence. This is the nearest equivalent in any of the diagnostic systems to the old notions of addiction. Addiction, that condition in which people are trapped by a substance. So substance dependence is defined conceptually in ICD-11 as a disorder of regulation of substance use, which arises from repeated previous use of that substance and consists of a central feature, a strong internal drive to use that substance and to continue using it. The diagnosis requires a pattern of substance use, which is manifested by two or more of three central features: impaired control, increasing priority of substance use, and physiological features. So you need two out of those three features over a certain time, which I shall describe, to make the diagnosis. So the first essential key feature is impaired control over the use of the substance. That means impaired control over when substance use starts, the duration of substance use, the termination, the person finds that they are unable to cease substance use voluntarily and may drink themselves, for example, to intoxication, or their control is impaired because they use a particular substance in a situation where it is very inappropriate. Say when they're operating electrical apparatus or heavy machinery. So impaired control is the first central feature. The second central feature is increasing priority or precedence given to substance use over other aspects of life, over other daily activities and responsibilities, but also over the preservation and maintenance of that person's health. And it may also be manifest that substance use continues or indeed may escalate despite the occurrence of harm or negative consequences. The third feature are the physiological features. These are indicative of the neuroadaptational changes in the mesolimbic system to repeated substance use. And they may involve increased tolerance to the substance, so that more is required to get the desired effect, or the occurrence of withdrawal symptoms when substance use ceases or reduced, or the use of the substance to prevent or alleviate withdrawal. So three central features, and you need two at least to make the diagnosis. And there is a time criterion as well. You need to have evidence of these features over a period of at least 12 months, though there is provision in ICD-11 that if all the features are present and they're very intense and continuous, you can make the diagnosis of substance dependence after 3 months. And that's particularly valuable if you have a patient who is using cocaine, for example, or gamma hydroxybutyric acid, GHB, where dependence on the substance can develop very quickly. I've just got a few more comments about substance dependence, and it's a very important diagnosis. The substance dependence notion in ICD-11 is a rationalization and a simplification of the corresponding diagnosis in ICD-10. In ICD-10, there were 6 essential features of which central features of which you needed to have 3 or more present to make that diagnosis. And of course, ICD-10 is what largely we would be using at the moment. So instead of 6 central features, ICD-11 has 3. And the reasoning behind that, and this was work that was done, as Professor Sawitri has mentioned, in the ICD-11 Substance Use Disorders Work Group, was that we were aiming to make it easier for people to understand what substance dependence is. And so it was to facilitate training and learning by health professionals as to the central feature of substance dependence. A number of studies have been undertaken looking at the concordance of ICD-11 substance dependence with its counterpart in ICD-10, and it was encouraging that concordance rates as measured by the kappa coefficient were extremely high. Typically for alcohol, for opioids and for cannabis, kappa coefficients averaging 0.95, which shows a very high level of agreement. Just a few other comments about substance dependence. Impaired control, as I've indicated, refers to the typical episode of substance use. A word about craving. Craving is a feature in ICD-10. It was eliminated as an obligatory feature from ICD-11 because although it is very prominent in some forms of substance dependence, nicotine, for example, heroin, it is not a characteristic feature in other forms of substance dependence. But craving is mentioned as a quite common accompanying feature in the description of impaired control. Increasing priority requires a longitudinal perspective. Here you're not looking at the individual episode of substance use. You're looking at the person's life and how that has changed over time in relation to the use of the substance. Has the substance taken a greater priority in that person's life? Has it squeezed out other responsibilities and other activities to the sidelines so that the substance takes a precedence, which we sometimes call center stage in that person's life? It now has a central importance, whereas some time before it didn't have that central importance. The physiological features are not an obligatory requirement for the diagnosis of substance dependence, although if they're present, they can contribute to that diagnosis. The reason is that physiological features don't exist, as far as we know, for some substances like hallucinogens. Physiological features are insufficient in themselves for the diagnosis of substance dependence. So if you don't have any of those behavioral features, the presence of a withdrawal state, for example, does not necessarily mean you have a substance dependence. This is important because people who are being treated with high-dose opioids for cancer pain, for example, can, if their opioid is interrupted, their opioid treatment is interrupted, can experience withdrawal. But the occurrence of withdrawal in that instance is insufficient for the diagnosis of opioid dependence. You would need to have some of the behavioral features present as well. The next diagnosis of these four central ones is harmful pattern of substance use. This is a sub-dependence diagnosis. It's one below that top one of substance dependence. It is defined as a pattern of psychoactive substance use which has caused, and I'm looking at the lower part of the slide, clinically significant damage to a person's physical or mental health, or has resulted in behavior leading to harm to others. So it's a repeated pattern of substance use which has led to identifiable harm. Physical harm, like a disease, mental harm, depression, for example, or because of the person's behavior, typically when intoxicated, has resulted in harm to others. The harm to the health of the individual may come from behavior, intoxicated behavior leading to injury. It may come from the direct or secondary toxic effects on body organs or systems, or it may come from a harmful route of administration, for example, injecting drug use leading to contracting HIV or hepatitis C. Harm to the health of others, well, one example would be a person who is in a relationship with somebody who has repeated alcohol intoxication, and as a result of that, they have experienced an assault, and they have developed subsequently a post-traumatic stress disorder. So that's an example of how a form of harm to another person, but arising from the intoxicated behavior of the person for whom the diagnosis of harmful pattern of substance use applies. And the pattern of substance use needs to be evident for a period of at least 12 months, or it can be diagnosed if it's continuous use after 1 month. This next diagnosis is a new one in the ICD system. It is episode of harmful substance use. It has no counterpart in ICD-10. And this diagnosis is defined as an episode of substance use which has caused harm to the person's physical or mental health, or behavior leading to harm to others, but there is no known pattern of substance use. This diagnosis is likely to be very useful in emergency departments. And the studies indicate that in that setting, it is a commonly made diagnosis. The harm may occur, again, from the mechanisms that I described for harmful pattern of substance use. And the reason for making this diagnosis is where the clinician thinks that the harm has resulted from a substance, but there is no information at that time on whether there is a pattern of substance use over the previous year or more, or whether the person fulfills the criteria for substance dependence. And so episode of harmful substance use is a diagnosis that you can apply in that situation where you don't have information about previous use of that particular substance. As and when more information becomes available on whether there is a previous pattern of substance use, this diagnosis may be replaced by a more specific diagnosis, such as harmful pattern of substance use, or of course, substance dependence. Now we come to hazardous or risky substance use. This is also a new diagnosis in ICD-11. It didn't exist in ICD-10. It doesn't exist in DSM-5. But it's not a disorder. Hazardous substance use is a health risk factor. It is defined as a pattern of substance use that appreciably increases the risk in the future of physical or mental harm. No harm has occurred at the time the diagnosis is made. But we know from epidemiological studies, or there is a view in that by the clinician that the person's pattern of substance use is likely to cause significant problems in the future, that person is at risk. The pattern of substance use may persist in spite of awareness of that person that their use is risky, but they don't reach the criteria for substance dependence. So the diagnosis of hazardous substance use, I think, is particularly useful for epidemiological purposes. And I'm really pleased that we've been able to incorporate hazardous or risky substance use in the ICD system, because it enables us to capture patterns of substance use which we know pose the risk of future harm and which properly are the target for our preventive and public health approaches. Now, as I mentioned earlier, there are also some specific clinical diagnoses to cover specific areas of disorder. They include substance intoxication and substance withdrawal. They include a range of substance-induced mental disorders. There are also, in the broader ICD system, a range of physical disorders which are related to substance use. In the ICD-11, these physical or medical disorders are to be found in chapters corresponding to the particular body organ or system. So, for example, you have alcohol-induced liver disease, alcohol-induced cirrhosis in the gastroenterology and liver disease chapter, whereas the substance-induced mental disorders are grouped in the same chapter as the 4 primary diagnoses and substance intoxication and withdrawal. Substance intoxication, the diagnostic guidelines are listed here. They will be very well known to you. Substance intoxication is defined as a time-limited syndrome, a time-limited effect of high doses of a particular substance. It applies to all psychoactive substances. And these diagnoses typically apply to discrete episodes of substance use. The essential features of substance intoxication in general are that there are transient but clinically significant disturbances in a number of domains: consciousness, cognition, perception. So that might mean illusions or hallucinations, affect, behavior or coordination, which are related to the use of that particular substance. Now, of course, we are dealing with substance groups which have very, very different pharmacological effects. And in ICD 11, there are tables which summarize the key features of substance intoxication for all those 14 substance groups in quite some detail. But time, of course, does not permit me to do that at the present time. I should mention that substance intoxication is a clinical diagnosis. It's not diagnosed by a particular, for example, blood alcohol concentration or a particular level of a drug detected in urine or saliva. It is a clinical diagnosis. The clinical diagnosis may be supported by the detection of a substance or a metabolite in a body fluid, and particularly if it's at high levels. But the diagnosis of substance intoxication should not be based on the presence or level of a substance in blood, urine, saliva, or another body fluid. It is a clinical diagnosis with those features that I've described of disturbances in consciousness, cognition, affect, coordination, and the like. Substance withdrawal. Substance withdrawal occurs in some people with substance dependence when they cease or reduce their level of use. It can also occur, of course, in people who've never been diagnosed with substance dependence, but who have a history of prolonged and/or high-level substance use. Again, the specific features of substance withdrawal depend very much on which particular substance you're talking about, and therefore on the pharmacological properties of that particular substance. So alcohol withdrawal is a very different syndrome to psychostimulant withdrawal. One is a state of heightened activity, and the other is a state largely of much lowered activity, inertia. Note that substance withdrawal can occur with prescribed medications, such as opioids, anti-anxiety agents, stimulant medications as may be used for the treatment of ADHD, even when they have been used in standard therapeutic doses. This is particularly important with the benzodiazepines, where there is plenty of evidence that people who've been on therapeutic doses of diazepam, for example, per day, equivalent to maybe 5 milligrams 3 times a day, can experience withdrawal when their diazepam is suddenly ceased. And this has been done in randomized controlled studies, which demonstrate that. As I said, the existence of a substance withdrawal state does not necessarily mean that that person has substance dependence. There are a range of substance-induced mental disorders. Now, these need to be defined very carefully. We're not just meaning substance dependence in a person who, substance use in a person who has experienced anxiety due to an intoxication or withdrawal state. We're also not talking about people who have an independent mental health disorder. We're talking about a group of disorders which are clearly related to substance use and which occupy an intermediate time frame between intoxication and withdrawal on the one hand and an independent mental disorder on the other hand. There are 4 substance-induced mental disorders which cut across the range of substances: substance-induced delirium, psychotic disorder, mood disorder, and anxiety disorder. 2 of the substance-induced mental disorders only apply to psychostimulants. That's psychostimulant-induced obsessive-compulsive disorder and psychostimulant-induced impulse control disorder. Point 5, substance-induced mental disorders typically last for several days, weeks, or occasionally months, but there must be a temporal relationship with substance use at the onset. And so, as I repeat again in point 7, substance-induced mental disorders exist in a time frame between that of the short-term syndromes of substance intoxication and substance withdrawal, and the typically longer-term timeframes of mental disorders that have no direct relationship with substance use. A couple of examples: substance-induced delirium, defined as an acute state of disturbed attention and awareness with the typical features of delirium. it can be diagnosed in a state of substance intoxication or substance withdrawal. And I suppose the commonest substance-induced delirium that we see is what is known as delirium tremens due to severe alcohol withdrawal. Substance-induced psychotic disorder is defined as a group of psychotic symptoms of which you'll be very familiar: delusions, illusions, hallucinations, disorganized thinking and behavior, but which is related in time to substance use, and particularly occurs during or soon after intoxication or withdrawal from the substance, but persists beyond the time frame of that intoxication or withdrawal state. There are a range of substance-induced neurocognitive disorders, including substance-induced amnestic disorder, of which the commonest is Wernicke-Korsakoff syndrome, substance-induced dementia, and then there is also substance-induced catatonia, defined as a neuropsychiatric disorder of the movement, which is really quite rare and probably one of the rarest of the substance-induced mental disorders that we come across. Now, I've mentioned that there are other substances than those specified. You can make a diagnosis of substance dependence, for example, due to another specified psychoactive substance. And examples of these other substances which can cause substance dependence and the other disorders that I've described are anabolic steroids, corticosteroids, antidepressants, anticholinergic medications, and antihistamines. The last probably largely through their and anticholinergic properties in addition. The diagnoses that I've described, which apply to the 14 specified substance groups, also apply to these other substances like anabolic steroids and the like. Then there are diagnoses of which apply to non-psychoactive substances. Laxatives, I've already mentioned, growth hormone, erythropoietin, and some over-the-counter medications and folk remedies. Now, these are not psychoactive substances, and they can cause harm, but by definition, they can't cause the range of clinical syndromes that I've described so far. So the only ones for which the only diagnosis which can apply to these non-psychoactive substances are harmful pattern of use and episode of harmful use. You can't diagnose laxative dependence or growth hormone dependence. That's not allowed in the ICD-11 system. You can make ICD-11 as complicated as you want to be, or as simple as you want to be. There are various specifiers and qualifiers. You can specify substance intoxication as mild, moderate, or severe. You can specify substance withdrawal as with perceptual disturbances, illusions, or hallucinations, with seizures, or with both perceptual disturbances and seizures. You can specify substance dependence in terms of its course, such as current use, current dependence, various forms of remission, as you will see there. Now, briefly, I'm going to move on to the non-substance addictive disorders. And there are two which are specified in ICD-11: gambling disorder and gaming disorder. These are defined in ICD-11 somewhat similarly to substance dependence, but not identically. Gambling disorder, for example, is characterized by a pattern of persistent or recurrent gambling behavior, which may be online, internet-based, or still more commonly offline. it is manifest by three central features. And in contrast to substance dependence, all three of these features are required for the diagnosis. Impaired control over gambling, similar to substance dependence. Increasing priority to gambling, similar to substance dependence, except that in item 3, you've got continuation or escalation of gambling despite negative consequences. And so what you see there is that the second substance dependence guideline has been split into two for gambling disorder and gaming disorder. So impaired control over gambling, increasing priority given to gambling over other activities, and also as a separate third, continuation of gambling despite harm. And importantly, and this is another difference to the diagnoses of substance dependence, this pattern of behavior is of sufficient severity to result in significant impairment in various areas of functioning or harm, as specified there. And the pattern of gambling must be evident over a period of 12 months or a shorter period of 6 months may be sufficient if all the features are present and severe. Gaming disorder. This is a new diagnosis in ICD-11. It didn't exist at all in ICD-10. It is characterized rather similarly to gambling disorder, a pattern of persistent or recurrent gaming, online or digital gaming, most commonly, which is manifest again by impaired control, increasing priority of gaming over other activities, or continuation or escalation of gaming despite negative consequences. Again, there is a requirement for the person to have experienced significant impairment or harm. And the time criterion is similar to gambling disorder. This is a table which I will not really comment on much, but tries to summarize the difference between gaming disorder in the second column, gambling disorder in the third column, and substance dependence. And you will note that we do not have physiological features as a key feature of either gaming disorder or gambling disorder. And the reason for that was that there wasn't sufficient evidence for increased tolerance to online games or withdrawal after cessation of gambling for WHO and the groups advising it to be convinced that these should be obligatory features for the diagnosis. Okay. Now, a little bit, I realize I've reached the end of my time, but just I think two concluding slides. The ICD system and WHO recognizes that there are variations in the presenting features of some human disorders. These may be biologically determined or culturally influenced. And so it recognizes that. And so there is a degree of flexibility for clinicians in the 200 countries in the world which will be using the ICD system to make a diagnosis that they think is most appropriate to the patients that they are looking at. The diagnosis is expected to occur by the clinician comparing the information from the patient's history, and any other information that is evident against the known features of the disorders, and applying an intellectual matching process to match up the patient's experiences with one or other of those diagnoses. Of course, as well as the interview information, importantly, there is the mental state examination. Physical examination is often helpful. And I'll just make a comment about the audit questionnaire, because the audit questionnaire does enable you to tap into those the features of substance dependence, hazardous substance use, and also harmful substance use. For example, questions 4, 5, and 6 of the audit tap into substance dependence. Question 4 taps into impaired control, the first of the 3 central features of substance dependence. Question 5 taps into increasing priority of substance use. And question 6 taps into the physiological features, and specifically withdrawal phenomena. As I mentioned, that in many settings, physical examination can yield additional diagnostic information, and further information can be obtained through identification of alcohol or a substance in a body fluid. There are also physiological markers, particularly useful for alcohol, which you will see listed there in point 11. And imaging studies can point to disorder of various areas of the brain and other body organs. This is particularly useful for identifying physical disease in the liver, the pancreas, etc. We don't have the specificity of brain imaging as yet, which will enable imaging studies to make a diagnosis of substance dependence or any of the other disorders for us. That requires our own intellectual abilities and efforts as clinicians to make those diagnoses. So I hope that has been a helpful summary of the ICD-11 substance use and addictive disorders diagnoses, and thank you for listening.
Okay, thank you very much, John, for your amazing presentation. So now we are going to have into the Q&A session. We have a lot of questions from our audience. Let me begin with Dr. Rasmon's question. Dr. Rasmon, would you like to ask John directly?
Oh, sure, yes. First, I would like to say that great talk and informative, and thank you very much for sharing your experience for the diagnosis, the new diagnosis. My first question is just very local to Thailand, because we have one substance that people in Thailand use a lot. For example, like mitragynine or kratom. And and if we have this patient who has kratom dependence, which one of the diagnosis classification we should use in the classification of you say from 9 to 14 in ICD-11 substances?
Yeah. It's very interesting that you raised the issue of the kratom, because late in the stage of development of ICD, I mean just 3 or 4 months ago, there was a lot of consideration given to including kratom as a specified substance because of its importance and its unique pharmacological properties. And I think as long as you push enough for WHO to take action, I think in the first revision of ICD-11, kratom will likely be included as a specified substance. So the ICD 11 substance use and addictive disorders have now been established. We're not expecting any more changes from now until January, when it will start to be implemented in countries around the world. But there is expected to be an amendment in 2022 and a more major amendment in 2024. And this is when kratom might be included as the 15th specified substance.
Okay, thank you very much.
At the
How
moment,
about, yes.
perhaps I can say, as a clinician, if you want to diagnose kratom dependence, you can do, and you use the ICD-11 code for another specified substance. And then using that code, then you also add a note that you are referring to kratom.
May I ask a following question? This question on the social aspect. Do you think it's good to include kratom as a specified substance in the ICD-11? John, you may know that 2 days ago in Thailand, we removed kratom from the narcotic law. Okay, and it was in effect on the 24th of this month, so two days ago. Okay. But I know that there will be a meeting with the WHO meeting and EMCDD something. Okay. To consider kratom, because in many countries they are going, like in the US, they used to put kratom under the controlled substance, but because of some movements from the users, so this law was pending until now, and many countries are in this status, okay, to put kratom as a controlled substance or a kind of narcotic. But Thailand is opposite of the other country. We remove it from our law. So what do you think in terms of social effect?
Yeah. Well, I think in general, when a substance moves from being very restricted by regulation to being less restricted or even unrestricted, the use of that substance goes up, and so does harm. And I don't have any data about changes in the law affecting kratom use, but in those states in the United States where marijuana, cannabis, has been legalized for personal use, there has been an increase in the percentage of certain sectors of the population which use cannabis. And generally, when the use of a substance increases, so do problems and harms arising from that substance. So I also know that in the United States, there is concern about the increase in kratom, particularly in the western states, such as California, and presentations with kratom-related disorders to healthcare settings, which had never been seen before in those areas. So I must say I'm surprised. I don't think it's right to have kratom in the sort of category that would apply to heroin, for example. And I'm aware that kratom is used by many people in the rural areas of Thailand, in villages, and has been used for centuries. But I'm just would like to express my personal surprise that regulation in Thailand has, as you say, gone in an opposite direction to many other places.
My next question is about the classification again, because we have some substance that people used to like to mix it. For example, like kratom again, the people use it like
Sorry, I didn't hear that. What was the example of the substance?
I would like to ask about the classification again, about the classification of the substances, and many people like to use many substances at the same time, and it's like another new substance. For example, like kratom, people use for recreational use, they mix with codeine, or they mix with tramadol, and then there is like a new substance. So or for example, like heroin, speedball, they mix heroin with cocaine, for example. And for the mixed substance, which one we should put them into which classification?
That's a very good and clinically relevant question. And ICD has chosen not to use a diagnosis of multiple substance use or multiple substance dependence in favor of specifying the individual substances which a person uses. Now, it does make it a bit complicated, and also, I will share my experience as a clinician of seeing many patients over the years who would use 6, 10, or 20 different individual substances, and their substance use was really quite broad and indiscriminate, and they often didn't choose substances of a particular pharmacological type. So they would take one form of depressant, another form of stimulant, a hallucinogen, a dissociative drug, sometimes together, sometimes one after the other. So ICD has chosen to require the clinician or the person making the diagnosis to specify, firstly, the most important substance. The substance which has caused or contributed to the greatest extent that particular syndrome. And then, having diagnosed that, you then go to the next substance. So, for example, let me say that a person uses methamphetamine, which is yaba, isn't it? Methamphetamine, and then they, a few hours later, they would use alcohol or a benzodiazepine or GHB in order to terminate the effect of methamphetamine. Now, what you do then is to make a primary diagnosis of maybe methamphetamine dependence, and then a diagnosis relating to the benzodiazepine, maybe of benzodiazepine dependence or hazardous use of benzodiazepines if no harm has occurred or something like that. So that's the way that the ICD system has evolved over time. I wish it had a diagnosis of multiple substance use, but it doesn't anymore.
Okay, thank you.
Okay, so next question is my question. So what is the difference between episode of harmful use and substance intoxication?
These are very good and perceptive questions. Substance intoxication may be clinically significant. The person needs assistance to recover. but they may not have experienced any particular harm. If they have experienced harm, then it is quite possible that episode of harmful use would be an appropriate diagnosis. Also, you can diagnose both. So you can diagnose episode of alcohol, episode of harmful use of alcohol, and you can diagnose in that patient also alcohol intoxication. So preference should be given to diagnose one of the primary disorders: substance dependence, harmful pattern of substance use, episode of harmful use, or hazardous substance use. But if it's clearly an episode of alcohol intoxication in this example, diagnose that as well.
Okay, thank you.
And in some healthcare systems, the more diagnoses you make, the more money you make. Or the more money the service or the hospital makes.
Yeah. May I ask another question, which is related to Bong Kwan's question? Okay, in terms of harm to other person in the diagnosis of harmful use. So in case of alcohol intoxicating person, like Bong Kwan said, and he causes harm to other people, for example, from fighting and injury. So should he be diagnosed as episode of harmful use or alcohol intoxication? He himself is in the intoxicating stage, but he causes harm to others.
It's understood that for most diagnoses of harmful use, that it would have occurred relating to intoxication. So in that very specific situation, the best diagnosis, which would cover everything, would be episode of harmful alcohol use.
For that person?
For that person, yes. And then the person who has been assaulted or who has been injured, then they would have a diagnosis in another part of the ICD system of relating to the specifics of their injury.
Thank you.
Okay, so I think that Dr. Savitri also have another question that related to the classification of the misuse of sport performance enhancing drug.
Yes.
So sorry, the use of.
Yeah, so the question is how ICD-11 classify the misuse of sports performance enhancing drug that was using by the athlete. Should it be classified in the disorder due to non-psychoactive substance?
Yep. If performance enhancing drugs are of two types. Some have psychoactive properties, and anabolic steroids would be a typical example there. But also other performance enhancing drugs include growth hormone and erythropoietin. These are not classified as psychoactive, but non-psychoactive substances. So there is no one diagnosis for all performance enhancing drugs. You have to work out whether they're psychoactive, anabolic steroids on the one hand, or on the other hand, whether they're growth hormone, erythropoietin, or some other non-psychoactive performance enhancing drug. But all the performance enhancing drugs will be captured by the ICD-11 system.
Okay, thank you very much. And we also have a question from Dr. Pichai. Dr. Pichai asked a question regarding the diagnosis of substance-induced psychosis. So his question is, what is the difference between the DSM-5 and ICD-11 in making the diagnosis of substance-induced psychotic disorder?
There is rather little difference between DSM-5 and ICD-11. And both require that some of the features, the typical features of a psychotic disorder, are fulfilled, and the onset of the psychotic disorder can be related to substance use, typically following acute intoxication or withdrawal. One difference between the two systems is that in DSM-5, substance-induced psychotic disorder is expected to remit in most cases after a month, whereas that time frame is not specified in ICD-11 because there are some substance-induced psychotic disorders which take several months to remit. An example is amphetamine or methamphetamine-induced psychosis. For example, there were studies back in 70 years ago of people taking amphetamine, which showed that in a controlled environment where they had no access to amphetamine, the psychosis would often persist for up to 6 months. And so you wouldn't, but would remit after that period. So in the longer term, they would not have any residual psychotic disorder, but it can be very persistent. Alcohol-induced psychotic disorder can also, in some people, persist over many, many months before it finally remits. So the ICD system accommodates that variation in the time course of substance-induced psychotic disorder. Whereas I think the DSM-5, I think the expectation is the psychotic disorder will have remitted after a few weeks.
Okay, thank you very much. So, Dr. Lasamon, do you have another question?
Yeah, related to Dr. Pichai's question, may I ask Professor Saunders about, in your idea, which is the duration that we should change the diagnosis from methamphetamine-induced psychotic disorder to like schizophrenia after they're stopping methamphetamine? You said that in the previous studies, say like 6 months, but in reality, sometimes they persist for like 15 months. But then the clinical symptoms by itself is not like schizophrenia, but we still use methamphetamine-induced psychotic disorder. So in your opinion, how many months?
When you look at the natural history of amphetamine or methamphetamine-induced psychosis in a controlled environment, so that you know that the person isn't accessing any more psychostimulant, a percentage of people, about 50%, will have remitted in 1 month. Another 40% will have remitted by about 4 months. A small percentage will have remitted by 6 months. And then you have a proportion of people, which typically is, about 8%, sometimes 10%, in whom you have features of psychosis and the need for antipsychotic medication. existing after 6 months. With alcohol, you have a similar picture, although not as high a percentage. About 5 to 6% of people with alcohol-induced psychotic disorder will have ongoing features of psychosis after 6 months. And at the 6-month point, as a clinician, you have to make a decision as to whether you then diagnose schizophrenia. Because after 6 months of features, you can diagnose schizophrenia with the 6 months requirement. And there are really no features of schizophrenia which are never seen in substance-induced psychotic disorder. I mean, I suppose you could say that some of the illusions, the hallucinations, or the delusions which are related to religious thoughts, thinking that, I suppose in the Christian societies, thinking that a person thinking that they are God or they're Jesus, and they have special properties, and God wants them to speak information to people. Now, those are very rarely seen in a substance-induced psychotic disorder, in my experience, but I have seen it. So you can't be guided so much by the actual features of the psychosis. And at a certain time, I would suggest 6 months, you then make a decision that that person likely has schizophrenia. Whether they originally had a prodrome before they started using methamphetamine, or whether this is a residual disorder, doesn't matter too much. But if they are still symptomatic at 6 months, they still require antipsychotic medication, then the treatment really becomes that of schizophrenia, with the added requirement to try and help that person reduce their access to psychoactive substances as much as possible.
Okay, thank you very much. My next question is about gambling disorder. That you said that if gambling is so severe, then we use the duration for 6 months to diagnose gambling disorder. So I would like to know how to consider the gambling is severe. Is there any cut point or some criteria for consider that gambling is so severe?
Yeah. Again, it's the clinician's decision.
Okay.
There are no detailed guidelines, and that reflects the fact that ICD tries not to constrain your ability to make a diagnosis. It kind of trusts the clinician to make the most appropriate diagnosis that applies to that patient in that particular country and culture. So, for example, if you had somebody who has been online gambling for 6 months, and during that time they have spent 1 million baht, then yes, that makes a diagnosis, doesn't it? Yeah, the clinician can say, well, this has caused such financial losses to that person that and such a degree of distress to his family that the diagnosis of gambling disorder is justified. On the other hand, if it's an intermittent pattern of gambling over 6 months, where there is some evidence of impairment, but it's not severe. The person has perhaps lost, maybe 50,000 baht, then you might think, well, that's not quite at the level that I would make a diagnosis of a gambling disorder. You'd still, though, want to give some advice and treatment for that person, but you'd probably, you might, for gambling, you would have to, diagnose hazardous gambling. At the moment, there isn't a disorder of harmful gambling in the ICD system. So that gives you some idea as to, weighing up how severe a particular condition is.
Okay, thank you.
Okay, so I think it's time now to move on to another session, to the case discussion, because we are. Yeah.
Yes, thank you very much. Could I just have 1 minute to just to have a glass of water?
Yes.
Now, I'm just trying to.
Actually, I think we have one question left.
Maybe we can ask after the
Dr. Thanawat. Okay.
Okay. All right. Well, thank you for those tremendous questions. I was really sort of pleased to receive them. I hope my answers have been helpful. Well, we've got the first case. We're now running a little bit behind time, but I'll try to speed up the case. And this is the case of a young man who had a methamphetamine issue. His name is David. I'm sorry, there's quite a lot of text here. His name is David. He's a 32-year-old man who works as a financial advisor. He seeks advice because of sexual problems. He's not been in a relationship recently, but he has had a lot of sexual encounters with other men who he does not know, anonymous sexual encounters. He has been twice treated for sexually transmitted infections. He reports using methamphetamine, and he calls it crystal meth. In Australia, we would call it ice, and I think in Thailand the most common name is yaba. He uses methamphetamine after work or on the weekends, sometimes drinks alcohol or smokes marijuana. Further history about his sexual problems. He reports that in his teen years, he was inhibited sexually. He never felt comfortable in himself, but drinking alcohol and smoking marijuana made him feel better in social situations. He would drink beer with his friends after sports matches, occasionally becoming intoxicated. He had his first sexual experience in his late teens when he had had a combination of alcohol and marijuana. And by his early 20s, he'd become more confident, both in general terms and in engaging sexually with others, and these were now exclusively men. David started working as a financial advisor, so he was quite an able person, good at sort of mathematics. He started working as a financial advisor when aged 27. He'd never used methamphetamine up to this time, but he was offered it at a party. He liked the feeling of it. He describes that he became more confident and dominant during sexual activity. And he was able to have different types of sexual activity that he would never have been able to try otherwise. This is an amalgam of 3 patients of mine and another patient not of mine. The detail of these activities does vary, but I'll leave you to speculate what they might be. Up to the age of 30, his methamphetamine use was restricted to weekends, but in the last 2 years, it has spread to his work days, and his use of methamphetamine can be for 3 or 4 days at a time. He's also increased the amount that he uses from 2 to 3 points, which is 0.2 to 0.3 of a gram per occasion, to 5 points now in order to achieve the effect, what he describes as that release. He's never injected any methamphetamine, but he has, over the last year, found himself thinking more about using methamphetamine and getting high with amphetamine, including during the working day. David further notes that on several occasions over the last year, he has left work early to use methamphetamine and also to pay for sex. His sexual behavior when intoxicated from methamphetamine has become more and more risky. He has paid for unprotected sex with male sex workers several times. He's had 2 episodes of sexually transmitted diseases, but no general health checkup now for 6 months. He spends a lot of time on the internet chatting with other men who he doesn't know, with a view specifically to scheduling sex with them. He says he enjoys his sexual activities on methamphetamine, but he doesn't achieve any lasting satisfaction. And as I've noted, he's not been in any relationship, in any personal relationship for 2 years. For a day or 2 after using methamphetamine, David becomes depressed and anxious. He reports that he tried to stop using for a week 2 months ago, but he became more and more depressed and irritable over that time. In some ways, he'd like to have a relationship and stop this anonymous sex, but drug use has become so much of a central feature of his regular life. He's been rude to 2 of the company's major clients, and the previous week he received a written warning by his employer that he needs to improve his performance at work or he will be dismissed from his post. So, which is the main focus of the referral? Why was he referred? And these are your choices. Anybody like to make a comment? Well, the reason he was referred is sexual problems. That's his focus. And of course, we realize that when we make diagnoses of a substance disorder, in many cases, the patient doesn't come to us saying, I have a substance disorder. They come with problems, with disorders, with symptoms. They may not relate this to their substance use. It's our role as clinicians to make the diagnosis, to be alert. So sexual problems is the reason that he is presented. Now we come on to...
Excuse me, but was he referred to you directly, primarily? Because if he was referred to us, who are psychiatrists, we would not think of sexual disorder or sexual problem as
Right.
reasons.
Yeah. Okay. All right. So he was, experiencing some concern about what he thought was a sexual problem, but then we have a lot of information about his substance use. And in terms of the principal diagnosis, these are some suggestions: compulsive sexual behavior disorder, methamphetamine dependence, social anxiety disorder, harmful pattern of alcohol use, and narcissistic personality disorder. Any suggestions for perhaps the main disorder? Well, we'll go on.
Methamphetamine dependence.
Sorry?
Methamphetamine dependence.
Methamphetamine dependence, yeah. Methamphetamine dependence is the principal disorder. Could he have compulsive sexual behavior disorder? We note that for many years he was sexually inhibited, and so he doesn't have a pattern of a primary impulse control disorder. Does he have social anxiety disorder? That's quite possible. More information, more exploration of that is necessary. But the dominant diagnosis now is methamphetamine dependence. The second diagnostic guideline for methamphetamine dependence is increasing priority or increasing precedence of methamphetamine use over other activities in life. And this is these are some choices, and this is the one which clearly shows that. He would like to have a relationship, but he feels that his drug use has become so much part of his regular life that it is of more importance than having a relationship, a settled relationship. Here we have the evidence for the diagnosis of methamphetamine dependence from this case report. And I think it might be easier, rather than my going through this, for you to have a look at this in your own time, and you will see the features that I identify as impaired control, other in green colouring, the features in the orange colour of increased precedence or priority, and the physiological features of tolerance and withdrawal, which are highlighted in the blue colouring. Also in the sort of reddish brown colouring, he does have features of craving, but as I said, that's not an obligatory feature for the diagnosis of a dependent syndrome. And again, you see throughout this case vignette pointers to impaired control, pointers to increased precedence, and pointers to some of the physiological features, making him qualify for 3 out of the 3 central features of methamphetamine dependence. Let's move on to the second case, and I think we will have some minutes for a question and answer. This case 2 is of a younger man. He's called Callum. He's a 24-year-old man, and he works as a motorcycle messenger, delivering packages, typically from the postal system or courier system throughout the city. One day, he was admitted to by ambulance to the University Teaching Hospital's emergency department. He'd had a serious road traffic accident. He'd sustained multiple injuries, including lacerations to his head, neck, and body, as well as several fractured ribs. Although he was wearing a protective helmet, he also sustained a head injury with brief loss of consciousness. CT and subsequently MRI scan showed that he had no serious structural damage to his skull or his brain. A standard toxicology screen indicated a blood alcohol level of 132 milligrams per deciliter or 28 millimolar concentration on admission. No other substances detected, and he was admitted to the trauma unit. He is seen by the liaison psychiatrist or addiction specialist 36 hours after admission. He does not recall all the details of the accident, but does state that he was drinking with some friends at a local bar. He explains he does not normally ride his motorcycle after drinking and does not remember why he did so on that occasion. With regard to his alcohol consumption, Callum reports a history of drinking 5 or more standard alcoholic drinks once or twice a week since his days in his late teens as a college student. He enjoys drinking with his friends and does not view his drinking behaviour as a problem. But he does say there have been a few times when I don't remember all the details after drinking, and I suppose we would regard that as experiencing alcohol-induced amnesic episodes or blackouts. He says he's not experienced any problems related to alcohol at work or any problems in his relationship with his girlfriend due to his alcohol consumption. He says sometimes he and his girlfriend have arguments because he would prefer to go out drinking with his friends rather than to go out to dinner with her. On further questioning, he says that he's had occasional hangovers, but he's never had any significant withdrawal symptoms. And he doesn't have any symptoms in between these occasional episodes of alcohol consumption. No significant past medical history, and he was in good physical health before the accident. He's never been diagnosed with any mental health disorders. He recalls being anxious before examinations in school, and generally has a concern that his results were not as good as some of his friends, but he did gain entry to a college after he left school. He has smoked marijuana in the past, occasionally, and on 3 occasions has taken ecstasy at parties. However, since becoming a delivery driver, he has not taken any substances other than alcohol. Oops, I'm sorry, I'm trying to move on. Okay. Now, this is a challenging question. Given the severity of this man's multiple injuries, I'm going to put forward the suggestion that consideration of his alcohol consumption and his an alcohol diagnosis is irrelevant. True? Is it irrelevant or false? Because it's important.
I think it's false.
So it is false. This is it's important to diagnose whether he has any alcohol disorder. He may have hazardous use, he may have harmful use, he might have alcohol dependence. It would seem that he's had alcohol intoxication. But have you ever been in an emergency department talking with an emergency department or trauma surgeon who is not concerned at all about a person's alcohol consumption? Yes, I have many times. It is frustrating, but we need to, all of us, recognize the importance of making these diagnoses, because there is an opportunity for an intervention for this young man He's had a very severe set of injuries, and surely we don't want him to be at risk of further injuries of this type. Which of the following points to the diagnosis of alcohol dependence? Let's consider that as a diagnosis. He's had multiple injuries. Does that mean alcohol dependence? He has an elevated blood alcohol level. He says his drinking behavior is not a problem. Or is it all those or none of those? Well, the answer is none of those. None of those are features of alcohol dependence. We should be concerned about those, but they are not diagnostic features of alcohol dependence. The primary diagnosis in Callum, what is that? Well, I'm going to suggest that it is harmful pattern of alcohol use. So look at his history. He has had a pattern of continuous, recurrent or sporadic use of alcohol over a number of years, and there is evidence of significant alcohol consumption on this occasion because of this elevated blood alcohol concentration. But also in the case history, we pick up that he's experienced significant harm, clinically significant damage to a person's physical or mental health. And he has had a number of injuries, but looking at all the information, he does not have features of alcohol dependence. And so his diagnosis is harmful pattern of alcohol use. If we did not know his past history of recurring alcohol consumption over several years, we would revert to the diagnosis of episode of harmful alcohol use, and we might also diagnose alcohol intoxication, depending on his state on presentation to the emergency department, and we would also diagnose the specifics of his injuries according to the ICD system. So those are two presentations. I'll leave this slide on for the moment in case we would like to refer to the two cases. And I think we have maybe just a few minutes, because I think that Dr. Tirath is probably ready now with his presentation, but I'm happy to answer any questions or have any comments from anybody participating.
So thank you very much, John. We do have a question that may not relate to the case, but Dr. Thanawat asked the question about the diagnosis of alcohol withdrawal delirium and delirium. So his question is, in a situation which is difficult to distinguish between alcohol withdrawal delirium and delirium, for example, a medical ill patient who has only mild autonomic hyperactivity of alcohol withdrawal and later complicated with some degree of delirium, which diagnosis should be made?
Make both.
Okay.
Alcohol withdrawal and alcohol-induced delirium. Make both those diagnoses. I mean, again, a very clinically relevant question, because an alcohol withdrawal-induced delirium, i.e. delirium tremens or DTs, is very commonly accompanied by electrolyte and metabolic disturbances. Hypokalemia is perhaps the most important of those, or a metabolic alkalosis. It is often accompanied by infection. Pneumonia is particularly for some reason upper lobe pneumonia is often is one very classical accompaniment to an alcohol withdrawal delirium, and the worst cases of alcohol withdrawal delirium that I've ever seen in my life have been in people with acute hemorrhagic pancreatitis. Now, of course, what I'm saying is you have a choice of making a diagnosis of alcohol withdrawal and a delirium if you think that the delirium is coming more from the other disorder, or you can make a diagnosis of alcohol withdrawal and alcohol-induced delirium if you think that the main driver is alcohol withdrawal, and particularly if you have a history of simple alcohol withdrawal in the hours or 1 or 2 days before the delirium develops. Note that alcohol withdrawal delirium typically starts about 48 hours after the last consumption of alcohol, and whereas an simple alcohol withdrawal is often 6 to 12 hours after last consumption of alcohol. So very often you have a period of hours or a day or so of simple alcohol withdrawal to point you that the main driver of the delirium is in fact alcohol withdrawal one.
Okay, so thank you very much, John, for answering our questions. So, and for the great presentation, it was a pleasure to have you with us today. So I think it's time now to proceed to another presentation from Dr. Thirayut.
Okay, so I'll now move on to my last slide and I will stop sharing. Okay.
Okay, hello everyone. Can you hear me?
Hello.
Yes.
Hello. Good evening, Professor Sonder, and good afternoon for Ajahn Savitri, Ajahn Pichai, Ajahn Lassamon, and Ajahn Pongkwan. And thanks for sharing case and for the informative presentation from Dr. Saunders. So I will share my slide. So I got the 15 minutes, right?
Yes.
Okay, so let's see. So this is my case presentation. And the source of data, I have a chance to interview a patient from drug addict clinic of Bangkok Metropolitan Administration. They have the clinic for their addiction treatment service. At that time, I used the SADA questionnaire or the semi-structured assessment for drug dependence and alcoholism to collect the data. It is the comprehensive interview questionnaire based on the DSM-4 criteria. And it used to collect the socio-demographic and data of the substance use and mental disorder. Here is the profile of the patient. He is a Thai male, 35 years old, Buddhist, divorced with the 2 children. His BMI is 17.4, quite thin. And he has 10 years of education. He works as a part-time employee. He also has a history of syncope 5 years ago and was diagnosed as having HIV 1 year ago. He also had a sexually transmitted infection, which is gonorrhea, for 12 years ago. He used to been admitted to the hospital twice for surgery of his hemorrhoid and vasculitis from drug injection. At the time of the interview, he is using alprazolam, diazepam, and amitriptyline for sleep problem, which prescribed by the psychiatrist at the clinic. And he also on the antiretroviral drugs. He takes methadone 65 milligrams per day from drug addiction clinic for 15 years. And the most preferred drug is heroin. And it is also the most problematic drug as well for him. He used to admit in the hospital for drug addiction treatment 10 times, which takes duration between 3 days to 4 months. The main caregiver is his father, whom he has a poor relationship with. He reports no exposure to the drugs, violence, or sexual harassment before 13 years old. He also reports the history of the antisocial behaviors from 13 years old with the ADHD symptoms since the 7 years old. And no depression, bipolar, or psychosis without drug use was reported. This is the first substance that he used. It is a cigarette smoking, about the nicotine. He smoked nicotine since he was 15 years old up until the date of the interview. He tried to quit once for 5 days because he felt sick at that time. And he also has the withdrawal when he stopped smoking, which include anxiety, agitation, and decreased concentration. And he has to smoke after waking up for a minute, which is the eye-opener smoker. And from the 20 years old, he smoked 1 pack of the cigarette per day, every day. And it can cluster into the group of symptoms by DSM-4, which include the withdrawal, spending time smoking, know the negative consequences, but continue to use. And he smoked large amount or long time than intention, which I think it will fit with the substance dependence for this ICD-11, that it show the impaired control by spending time or large amount or long time than intention. Increasing priority by spending time or cannot cut down, although he know the consequence. And he also has the withdrawal symptoms, which show about the physiological disturbance. About the second substance is the alcohol. He drinks since he was 14 years old up until now, but he drinks occasionally, not like in the smoking cigarette, which he regularly smoke. He report about having flushing and headache when drink, but never stop drinking. And the daily maximum of drinks is 8 drinks per day. At age of 25, he drank once a month for 6 months. The yellow bar shows about the heaviest use. He report he never had a problem with alcohol, no relationship problem, no occupation problem, no accident from the drinking, no legal issue, or no health consequences. And he report that he never had the withdrawal symptoms. I think his characteristic of drinking is not fit with the dependence, but he also reports with some physical symptoms, including the flushing and headache, and he also drinks more than 2 drinks per day, like that. I think it will fit with the harmful pattern of substance use for the ICD-11. About the third one is the methamphetamine or MA. He smokes methamphetamine since he was 20 years old, and then he shift to IV injection since at the age of 25 until the date of the interview. At the age of 23, he used MA at least once a week for 3 months. He used to use MA every day for 3 pills per day, and he used to mix it with the methadone or midazolam. He also report about having history of psychosis when using methamphetamine continuously, including the persecutory delusion or auditory hallucination, which I think it will fit with the substance-induced psychotic disorder. He also report about the withdrawal symptom when he stopped taking the methamphetamine, including agitation, fatigue, increased appetite, hypersomnia or insomnia, craving, nightmare, or psychomotor retardation. And he can abstain from MA 3 times, which take duration between 4 months and 2 years. Since the 23 of age, it can cluster in the group of symptoms, including the withdrawal, know the negative consequences, but continue to use. He cannot cut down, and the methamphetamine can impair his socialization, which I think it will fit with the substance dependence criteria. About the fourth one, which is the most preferred and most problematic drugs, is the heroin. he inject heroin since he was 18 until 35. And by calculating, he reported that he totally used the heroin for 3,000 days. And the last dose is within 2 weeks from the date of the interview. He used to share the needle with others, which led him to have the HIV. And he also reported about the history of vasculitis, which he has been treated in the hospital. He used to mix heroin with midazolam and amitriptyline. He reported about the opioid withdrawal symptom, and he also had a problem with the police. He got arrested for heroin abuse at some time between this period. And he take methadone since he was 19 years old. And from 19 years to 21, he reported about the heaviest use between these 2 years. And from the 20 years old until the 35, it can cluster in the DSM-4 TR criteria for substance dependence, or all of this. Tolerant withdrawal spending time, know the consequence, but continue to use, cannot quit large amount or long time than intention, and impair socialization will fit with the substance dependence for the ICD-11 also. About the fifth one is the sedative drugs, which he report about the substance that he takes not related with the prescription from the psychiatrist. He also uses off-label from the midazolam and to alprazolam or diazepam. And he used it since 25 by IV injection with heroin or methadone. He used to share needle with others within 3 months. He reported about the withdrawal symptoms of the benzodiazepine. And due to heavy use, sometimes during the period, he reported about having child neglect. And he can abstain from the using of the sedative drug for 3 times. And during the age of 30, he reported about the heavy use of the sedative drugs, which represent that he used the sedative for 4 times a day, 20 days per month for 6 months. And it can be clustered from the 30 years old that he has the tolerant withdrawal spending time, cannot cut down large amount for a long time than intent. And he also have the impaired socialization, which I think it will fit with the substance dependence. About the last one is the cannabis. He also reports just a brief or short period of use it in the adolescent from 18 years old to 20 years old. He report about the amount or the day that he used, that the total he used it around 20 times. And in the period that he report about the heaviest use, he report only once a day for 4 days a month. And he also mentioned that he didn't have any withdrawal symptom and no problem from smoking cannabis. And I think this is fit with the hazardous substance use, because when you use the illegal drug, you also increase the risk for having problems sometime in the future. Okay, thank you. This is my presentation. Please stop sharing.
Thank you very much, Dr. Thierry. So, Dr. John, do you have any comments on Dr. Thierry's presentation?
Perhaps I can make some comments on an excellent presentation with a very complex history of substance use, encompassing several different pharmacological classes of substance. And I'll just make some comments. I agree with all your diagnoses, possibly with the exception of harmful alcohol use. but let me take them one by one. Nicotine dependence clearly fulfills the criteria for impaired control and withdrawal, so he clearly has, and also having a cigarette soon after he gets up, which is could be prevention of withdrawal by further use of nicotine. So he has nicotine dependence. With regard to alcohol, you described him as having a flush reaction. I didn't think that he had many other specific problems. He says that he doesn't have any problems from alcohol itself. I may have missed something, but I wouldn't regard the flush reaction as constituting a form of harm. I did wonder whether he might have a deficiency in aldehyde dehydrogenase, and I wondered whether he might be of sort of Chinese Thai ethnicity, because that's more common in people who have Chinese Thai ethnicity rather than particularly in the north of Thailand, rather than people who are maybe 100% Thai. That is interesting. So my diagnosis on the basis of the information that I saw and understood was that he probably has hazardous alcohol use. The third diagnosis is methamphetamine dependence, and as you say, he fulfills all of the criteria for methamphetamine dependence. He also, it's a long-term diagnosis, and he's also fulfills the criteria for substance-induced psychosis, as you indicate, and very prominently, despite the fact that he's had a methamphetamine-induced psychosis, he's continued to use methamphetamine, so he's continued to use despite harm. The most severe diagnosis is heroin dependence, and he seems to have had a history of round about 8 years in all. He shares needles, and so he's had significant harm, but he fulfills the dependence features of the withdrawal and continued use despite harm, and so clearly has heroin dependence. And I wondered whether he had shown a response to being on methadone. I'd be interested in knowing whether, initially he was not treated with methadone and maybe had recurring admissions for detoxification, and whether he's shown a response to methadone. I'd also be interested in knowing what the dose of methadone is. You may have said, and I may not have seen it, but I guess for him, a higher dose of methadone rather than a lower daily dose would be useful for him. He has also sedative dependence, manifest by impaired control, tolerance and harm, and continued use despite harm, and note the history of child neglect. And then hazardous cannabis use, which seems to be the least of the issues that he has. But you've got 6 substance use disorder diagnosis, or 6 substance use diagnoses, as well as methamphetamine-induced psychotic disorder, and also a number of physical disorders that he has. So yeah, this is a guy who has so many substance use disorders, you could teach a whole medical school full of students on him alone. So thank you for that presentation. Oh, also I'd make a comment that he does have underlying antecedent vulnerabilities particularly in terms of ADHD. I'd be interested in knowing whether he was treated early or not with stimulants and perhaps educational behavior therapy as well. And he has antisocial personality disorder, which increases the risk of substance dependence by up to 10 times. So that's a very, very significant underlying risk factor for him. So looking at his underlying risk factors, he is exactly the sort of person who one might anticipate would develop a severe substance dependence. And as I said, and as you've said, he's got 6 substance diagnoses. Yeah.
Yeah, thank you, Professor Saunders. I think he's never been treated for the ADHD because I just detect the ADHD symptom from the interview using the questionnaire. Just only that.
That's an important comment that you've made, because the risk of developing a substance use disorder in the later teens and in adult life is increased between 4 and 5 times if you have untreated ADHD compared with the usual risk in the community at large.
Okay, so I think we have like 10 minutes left. So if anyone has,
I think Ajahn Pichai would like to say something. Ajahn Pichai, open the microphone.
Ajahn Pichai, do you have anything to comment?
Okay, okay.
Okay, so Ajahn Rasamon, do you have anything to comment right now?
I think the presentations say a lot about these persons, and I think you sat down for the interview and can capture many substances. One of my comments is that related to each of the substances, or some substance diagnosed for like 10 years ago or something. So in the clinical diagnosis, when we make the diagnosis in the ICD-11, back to the ICD-11, should we put this diagnosis in the current one, or if there are any diagnosis to state about the previous substance use, because something that we need to be concerned, because we know that substance use disorder is like a chronic diseases.
Yes, if perhaps I can make a comment. I think that unfortunately the sound I'm getting is fading at the moment. I don't know why. And my computer screen has gone, the extended one has gone blank. So anyway, fortunately that's happened only in the last few minutes. You can, I mean, there is a view that substance dependence is a diagnosis which applies for that person's life. But it can, of course, go into remission. So I would suggest that emphasis should be given to the diagnoses which apply at the present time. But somebody who has a history of a substance use disorder 5 years ago or even 10 years ago, you can make a diagnosis of, for example, in ICD-11, you can make a diagnosis of substance dependence in long-term remission. And that's defined as 3 years or more in remission. Or you can diagnose it in early remission, between 3 months and 12 months, and in medium-term remission between 12 months and 3 years. So the advantage of making a diagnosis of substance disorders which are not current is that they can indicate a vulnerability. And a common vulnerability that we see is where a person has a history of opioid dependence, for example, injecting heroin dependence, and who has perhaps had a period of treatment for some years with methadone or buprenorphine, or alternatively has gone into a rehabilitation program and is no longer using any opiate. But let us say that person requires surgery. They may need a hip replacement, for example, 20 years later. Because of their past history of opioid dependence, that person is vulnerable to reactivating or reinstating their opioid dependence when they are administered therapeutic opioids for post-operative pain management following the hip replacement. Now, that does not mean that we should deny them appropriate analgesia post-operatively. That would be very inappropriate and be cruel. But we must recognize that there is a risk in that person of the opioid dependence being reactivated, of tolerance to the post-operative and opioid analgesia developing, and for that person to develop the behavioral features of opioid dependence. And I've seen this in surgical wards, in orthopedic wards, on a number of occasions in my career. And you have to manage that. You have to tell the patients that that this is what is happening. Explain that you will perhaps enable their opioid analgesia to be switched to methadone or buprenorphine, or institute a detoxification regime, maybe using clonidine. So it is useful for good clinical care to be able to at least note the fact that substance use disorders from previous years existed, even though they've not been active for some length of time, because there is the capability of their being reactivated. Now, I'm not sure whether that directly answers your questions and comments, Rasmon, because as I said, the transmission of the sound has gone down, and I find it a little bit difficult to hear now.
You answered very well.
Okay, so
thank you very much.
Thank you very much. I think it's time now to move on to our last session, which is the wrap-up session by Dr. Lasamon, since we have 10 minutes left.
Mm-hmm. So we use last 10 minutes to, first of all, thanks Professor Sanders for excellent presentation and case, and Dr. Thillayut for the case presentation. And thank you, Ajahn Savitri, Ajahn Pichai, for being a chairman for this session, and Ajahn Pongkwan for being a moderator, and also everyone in the back office, Kun Titima, Kun Somrak, and Kun Cha, to organize a very well, coordinate everything that make this happen today. So today we learned a lot about the ICD-11, and we know about the difference between ICD-10 and ICD-11, and also ICD-11 and DSM. So I think in my conclusion, I think that the main difference between ICD-10 and ICD-11 is like for the number of substance that be in the classification. So we move from 9, right? So now we have like 14 classification substances. And then for the diagnosis, we need just remember just 4 diagnoses, that's all. But So it's very simple for ICD-11 to be used in general. And the first one is substance dependence, right? And the second one is the harmful pattern of substance use. The third one is the episode of harmful use. And the fourth one is like a hazardous use. So I know that being a clinician is very difficult for us sometimes to know the difference between these four diagnoses, but I think this is the beginning that we will try to understand more about each diagnostic criteria. And Professor Saunders said very clearly about the difference between DSM and ICD-11, that for DSM is like just one diagnosis, and we have mild, moderate, and severe for substance use disorder. But for ICD-11, we have 4 diagnoses, and be careful about diagnosis like this, because it's like a hierarchy, right? Because if someone have a more severe hierarchy of one of these 4 diagnoses, we need to go to the higher hierarchy to diagnose that person. And also, Dr. Saunders said a lot about intoxication, withdrawal that needed to be put into the diagnosis as well. I think another thing that's very important is like the change between the symptom criteria in ICD-10 and then move to ICD-11. That in ICD-10 we have like 6 criteria, but in ICD-11 have only 3, and very simple, more simple to diagnose for substance dependence. I think this is very, very important. And also I need to remind myself that craving is not the criteria for substance dependence anymore in ICD-11. And other than that, Dr. Saunders said about gambling disorder, and I think this is very, very good that to emphasize that to make the diagnosis, the criteria for making the gambling disorder is just like substance dependence. But for the third, I think main criteria that change just a little bit from physiological response to just increasing the amount of playing the gambling. So that's the one thing that is the difference that I think is a very important thing. And then Dr. Saunders also talk about other psychoactive substance and non-psychoactive substance. And this one, I think we need to emphasize that for making the diagnosis of the non-psychoactive substance, we should not have like dependence or so it's like just the hazardous or harmful the pattern of use, but not dependence, that should be diagnosed for the non-psychoactive substance. And I think for this diagnosis in Thailand, I think we may have this diagnosis a lot, because we have non-psychoactive substance and people kind of use it in general without any knowledge. For example, like herb medicine. So we may have this diagnosis a lot, but may not come to our office like a psychiatrist, but go to, in general. So I think that's all that I think the important thing that I myself personally keep it in my journal. And again, I would like to thank everyone for participating in this symposium. And for the Center for Addiction Studies, we will have this kind of conference every month. And but for this one very special event that the Center for Alcohol Studies organized this event and invite Professor Saunders to give us some very excellent presentations, and thank you everyone again. Okay, I think that's all for this evening, and stay safe everyone. Professor Saunders, good night.
Thank you. Thank you very much indeed. I greatly appreciated the opportunity of giving this presentation and participating in the discussion and listening to and commenting on Dr. Tierath's presentation. So thank you all very much. And I also note a number of participants I have met in Thailand, and also one or two who I think I've not met, but I know by reputation. So it's great to be involved in this session. And again, thank you very much. And goodbye now from Sydney.
Thank you very much.
Bye.
Bye. See you again sometimes.
Okay, indeed.
So I think that's all for today's, and as Ajahn Lasmon said, Center for Addiction Study regularly set up a meeting every month. So if anyone interested in joining in the conference like this, please follow us at our Facebook page. We will announce monthly. So that's all for today. Thank you all for the audience, and goodbye.
ค่ะ
สวัสดีค่ะ
สวัสดีครับ
สวัสดีครับ
สวัสดีครับ